Imagine running a marathon. But instead of wearing like high-performance running shoes, you're wearing these heavy, lead-lined, deep-sea diving weights.
Oh, right. Just strapped right to your ankles and your wrists.
Exactly, strapped to your wrists, your ankles. And every single time you try to lift your foot, you are fighting against this immense, unnatural downward pull.
Like gravity is just dialed up to 10.
Yeah, exactly. Every time you swing your arm, your muscles have to strain, 10 times harder than they normally should just to complete a basic motion.
Which is exhausting.
Beyond exhausting, that relentless, invisible fight against gravity, that is the daily reality for an infant born with PURA syndrome.
It really is. It fundamentally rewrites the rules of physics for that child's body. I mean, we take gravity entirely for granted.
Because we don't even think about it.
Right. Our neurotypical bodies have evolved to subconsciously push back against it every single millisecond. But when that automatic pushback isn't there, simply existing in space becomes this monumental physical effort.
Welcome to the PURA Syndrome podcast. If you are listening to this, chances are you are a parent, a carer, or a family member of a child who has been diagnosed with PURA syndrome.
We see you. We definitely know you're out there.
Yeah, we really do. And today's deep dive is custom built specifically for you. Our mission today is to tackle, well, a defining feature of PURA syndrome.
Something you've probably heard a lot of doctors casually refer to as Floppy Baby syndrome.
Right, but medically, clinically speaking, we are talking about hypotonia.
And we are not just going to skim the surface here. We have a massive stack of sources to guide us today.
Oh yeah, we are going deep.
We really are. We're pulling from comprehensive clinical and genomic analyses of 5q31.3 related neurodevelopmental disorders.
Which is a mouthful, but so important.
Exactly. We're also referencing the official care guidelines from the PURA Syndrome Foundation. Plus, we've got highly specific surgical and anesthetic protocols from orphan anesthesia.
Oh, those are crucial.
Absolutely. And a recent incredibly detailed scoping review on developmental central hypotonia, along with hands-on therapeutic insights from the Napa Center.
So we're going to use all of this to decode what hypotonia actually means inside your child's body. We're going to track how it causes this massive ripple effect.
Like how it impacts feeding, breathing, even bone growth.
Exactly. But most importantly, we're going to completely reframe how we look at progress. We are going to talk about why, for a child with PURA, we need to celebrate inchstones just as fiercely as the rest of the world celebrates milestones.
Because once you grasp the sheer mechanics of what your child is fighting against, you realize that every single inchstone is a hard-won, staggering victory.
Okay, let's unpack this. We have to start at the very beginning of the timeline.
Right, day one.
Yeah. For almost every single family navigating PURA syndrome, this journey kicks off in the neonatal intensive care unit, the NICU.
Which is such an overwhelming place.
Yeah. It's terrifying. Those first few hours and days, they're usually just a blur of panic and monitors beeping. The doctors and nurses are hovering around the incubator, and the very first clinical observation they make is usually about the baby's muscle tone.
That the baby feels floppy.
Exactly. They lack that natural newborn curl, when a baby pulls their arms and legs in tight. But I want to pause right here. When a doctor holds a baby and says they have low muscle tone, what exactly is happening under the skin in that exact moment?
Well, let's look at the sheer prevalence first, just to understand how fundamental this is to the condition. Severe neonatal hypotonia is a nearly universal feature of PURA syndrome.
Wait, nearly universal, like what percentage?
We were talking about it being present in over 95% of infants with this condition. It is the hallmark symptom. But the most critical distinction that has to be made, and this is something that dictates the entire course of the child's care, is the origin of this hypotonia.
Okay, the origin.
Yeah. We were talking about central hypotonia.
Okay, central meaning it's coming from the central nervous system, like the brain.
Precisely. This is opposed to peripheral hypotonia.
Which would be what exactly?
Well, in peripheral neuromuscular disorders, like spinal muscular atrophy or SMA, for example, the issue actually lies within the muscle tissue itself, or in the peripheral nerves that are directly plugging into those specific muscles.
So the muscles themselves are the problem in those cases?
That's right. In those peripheral conditions, the muscles themselves might be physically deteriorating, or they just lack the fundamental biological machinery to contract at all. But with PURA syndrome, the muscle tissue itself is perfectly physically intact.
Okay, I'm trying to visualize this. If a baby is just lying there floppy, how does a doctor in the NICU actually know the muscle itself isn't broken?
It's a great question.
Do they just guess based on other symptoms, or do they have to do, like, a muscle biopsy right away?
Oh, no. There's actually a very specific, much simpler physical test they do right there in the NICU. Have you ever been to the doctor for a physical and they tap your knee with that little rubber reflex hammer?
Oh, yeah, and your leg kicks out involuntarily.
Exactly. The deep tendon reflex.
You can't control it, it just happens.
Right, because that kick is a localized reflex arc. The tap stretches the tendon, a signal goes to your spinal cord, and the spinal cord instantly fires a signal right back to the muscle, telling it to contract.
It bypasses the brain entirely.
Exactly. It doesn't even go all the way up to your conscious brain. Now, when a neurologist takes that little pediatric reflex hammer and taps the knee or the ankle of an infant with PURA syndrome, those deep tendon reflexes are typically preserved.
Wow, so the tiny leg actually kicks.
It kicks, and that kick tells the clinician a massive amount of information right away.
Okay, so the local circuitry is working.
Right. It proves that the nerve connecting the spinal cord to the muscle is fully functional. It proves the muscle fibers are capable of contracting forcefully. The peripheral hardware is completely fine.
So the problem is central.
Yes, it's originating higher up in the brain.
So if I can try an analogy here to make sure I'm getting this, it's not that the hardware, like the muscles, the actual motors of the body is broken. The motors are fine.
Yes, exactly.
It's that the master computer, the brain, is sending an incredibly weak Wi-Fi signal to the hardware. The signal just isn't strong enough to tell the motors to stay engaged.
That analogy is excellent. But let's take it one step further into the genetics to explain why that Wi-Fi signal is so weak in the first place.
Yeah, let's get into the genetics.
The signal dropout happens because of a disruption on chromosome 5, specifically at a location called the 5q31.3 locus.
5q31.3. Got it.
This is the exact neighborhood where the PURA gene lives.
And the sources point out that this specific gene is biologically unusual, right? It's called a single-exon gene. But what does that actually mean functionally? Why does it matter that it only has one exon?
Think of a typical gene, like a massive instruction manual that tells the body how to build a specific protein. In most genes, this manual is broken up into chapters. Those are the exons.
Okay, chapters are exons.
Right, and they're separated by pages of basically gibberish. Those are called introns.
Just filler text.
Exactly. When the body reads the manual, it splices all the useful chapters together and just skips the gibberish. If there's a typo in the gibberish, it doesn't matter. The body just edits it out.
Oh, I see. It has a built-in proofreader.
Yes. But a single exon gene, like PURA, has no chapters and no gibberish. It is one continuous, uninterrupted block of vital code.
Oh, wow. So if there is even a single typo anywhere in that continuous block.
The entire manual is compromised. There is absolutely no editing process to save it. And that sequence integrity is incredibly critical because the PURA gene provides the exact instructions for making a protein called Pur-alpha.
Okay, Pur-alpha. The sources describe this protein as being highly conserved across evolution.
Which means it's incredibly important.
Right, like biology hasn't changed it for millions of years because it works perfectly. I read it described almost like the brain's ultimate project manager. But how does this project manager actually work?
Well, if Pur-alpha is the project manager of the brain, the individual brain cells, the neurons, are the construction workers, and they have a massive job to do.
Building the brain.
Yeah, they have to build trillions of complex synaptic connections. These are the bridges that allow brain signals to actually travel to the muscles.
Okay.
Now, the construction workers have all the bricks they need. Those are the basic amino acids floating around in the cell. But they don't know what to build or where to build it without blueprints.
And the blueprints are the messenger RNA, right, mRNA.
Exactly. The brain creates these mRNA blueprints in the center of the cell, the nucleus. But a neuron is a very long, spindly cell.
Right, they stretch out.
So to build a connection at the far end of the neuron, the blueprint has to be physically transported all the way down the length of the cell. This is what Pur-alpha does.
Oh, so it's the delivery guy.
Yes. It binds to the RNA blueprint, acts as a vehicle, and transports it to the translation sites at the far edges of the brain cell. So local proteins can be synthesized to build the actual connections.
So Pur-alpha is literally handing out the blueprints to the construction workers on site.
Yes. It is vital for the proliferation of neural cells, the maturation of dendrites, which are the branches of the neurons, and the formation of the synapses.
But when a child has PURA syndrome, one of their two copies of the PURA gene has a variant.
Right. And the most common one is called a P5330 mutation.
Yeah, I saw that exact term in the genomic analysis. What does P5333 actually translate to in plain English?
It's basically genetic shorthand. It means that at position 233 in the protein chain, a specific amino acid called phenylalanine, abbreviated as Phe, has been deleted.
Just one tiny missing brick.
One missing brick. But because it's a single-exon gene, that one missing piece means that entire copy of the gene produces a non-functional Pur-alpha protein.
Oh, man. So suddenly you lose exactly half of your functional project managers.
If we connect this to the bigger picture, the brain's project management team is suddenly working at 50% capacity.
Which is a huge deficit.
It is. The blueprints just aren't getting delivered to the construction workers fast enough. The neural pathways, the Wi-Fi routers, going back to your analogy, they don't get built robustly.
And so the signals telling the muscles to maintain tone, to hold posture, and to resist gravity, they are dramatically weakened.
Exactly.
That is such a profound way to understand it. I feel like it completely shifts how a parent might view their child's physical therapy.
How so?
Well, the therapy isn't about rubbing or fixing a broken bicep or a broken leg muscle, It's entirely about neuroplasticity.
Yes, exactly.
It's about training the brain to boost that weak Wi-Fi signal, essentially forcing the remaining project managers to work overtime to deliver those blueprints.
That's exactly it. The muscle is waiting. We just have to help the brain send the command.
But here is where the reality of central hypotonia gets incredibly urgent. Because in those early NICU days, this weak Wi-Fi signal isn't just affecting the arms and legs. We aren't just talking about a baby who can't wave.
No, not at all.
We are talking about muscles we don't even consciously think about. We are talking about the muscles required for basic human survival.
And this is the terrifying reality for a family of a newly diagnosed newborn. Central hypotonia profoundly impacts the autonomic nervous system and the core muscles required for life support.
Let's look at feeding first, because reading through the stories, it's usually the most immediate hurdle parents face.
It is. The clinical data shows that over 80% of PRA neonates have significant feeding difficulties.
80%. That is a staggering majority. And the clinical term the sources use here is dysphagia, which sounds so clinical and, I don't know, sterile, but it's actually a life or death mechanical issue.
Yes, dysphagia simply means impaired swallowing. But we really need to unpack what swallowing actually entails, because we take it completely for granted.
Right.
For a newborn, feeding from a breast or a bottle isn't just opening their mouth. It requires a highly coordinated, rhythmic, exhausting gymnastics routine called the suck, swallow, breathe cycle.
Right, because the airway and the food pathway share the same space in the throat.
Exactly. Think about the mechanics for a second. The baby has to latch using the orbicularis oris muscle around the lips. They have to create a strong vacuum seal.
Which takes tone.
Yes. Then the tongue has to ribble backward to push the liquid. Then, and this is the critical part, the soft palate has to lift to close off the nasal cavity, and the epiglottis has to fold perfectly over the trachea, the windpipe, so milk doesn't go into the lungs.
It's a lot of moving parts.
It's a huge sequence. Then the esophageal muscles have to contract in a wave to push the food to the stomach. Then they have to open the airway, take a breath, and do it all over again. 1, 2, 3. Suck, swallow, breathe.
That's incredible when you break it down like that.
It involves half a dozen cranial nerves and dozens of tiny muscles firing in perfect, rapid sequence.
And if the brain's project managers are working at 50% capacity, that complex sequence just falls apart.
It does. The muscles tire incredibly easily, or they misfire entirely. The timing just gets sloppy. And when that happens, the epiglottis might not cover the windpipe in time. This leads to a massive risk of aspiration, where milk goes down the wrong pipe and settles in the lungs, which can instantly cause a severe, life-threatening pneumonia.
Which explains exactly why, as a parent, you suddenly see all these interventions happening in the NICU. This is why there is such a frequent need for temporary nutritional support via nasogastric tubes.
Right, NG tubes.
Yeah, NG tubes, which go up the nose and down the throat. You are entirely bypassing that dangerous suck, swallow, breathe gymnastics routine.
And in cases where the central hypotonia remains severe and the dysphagia just doesn't resolve in those early months, parents often face the decision for surgical placement of a gastrostomy tube, a G tube.
Directly through the abdomen into the stomach.
Exactly. It ensures the child gets the calories they desperately need to grow their brain without the constant risk of choking or aspirating.
And to compound the misery, because it really is a cascade, the hypotonia doesn't stop at the throat. It goes all the way down the digestive tract. The sources highlight gastroesophageal reflux disease, or GERD, as being extremely common.
Because the sphincter, the muscular ring at the top of the stomach that is supposed to stay tightly closed to keep stomach acid down, is also a muscle.
Oh, of course.
And it is receiving that exact same weak Wi-Fi signal. It's floppy. So acid washes back up into the esophagus, causing extreme pain and further complicating the feeding aversion.
It's an entire cascade effect just from that one missing piece of protein, and it extends to breathing, too, which, honestly, reading through these sources is undeniably the most terrifying hurdle.
It's the one that keeps parents awake at night.
Absolutely. The data shows that more than 50% of these infants experience recurrent apneas, pauses in breathing. Now, I have to ask a blunt question about the mechanics of this because I want to make sure I understand it. If the muscles are just floppy, how exactly does that lead to an airway getting blocked during sleep?
It all comes down to physics, anatomy, and negative pressure.
Okay, break that down for me.
When any baby goes to sleep, their entire muscular system naturally relaxes. That's normal. But in a baby with severe oropharyngeal hypertonia floppy muscles in the mouth and throat, that relaxation is extreme.
So they get too relaxed.
Yes, the muscles of the upper airway, the throat, the base of the tongue, the soft palate, they become entirely slack.
Okay, so they are slack, but why does that actually block the air?
Because when the diaphragm pulls down to take a breath, it creates a vacuum negative pressure in the windpipe to suck air in.
Right.
If the walls of your throat are firm, the air rushes down smoothly. But if the walls of your throat are completely floppy, that negative pressure acts like sucking too hard on a flimsy paper straw.
Oh, wow. The straw just flattens.
Exactly. The walls of the airway physically cave in on themselves, they collapse, totally obstructing the flow of air. That is obstructive sleep apnea.
So the hardware is literally sagging and crushing its own pipe because the software isn't telling it to stay rigid.
That's exactly it. But PURA syndrome also causes something called central apnea. And this is a completely different and arguably more frightening mechanism.
Wait, hold on. A different mechanism. So the airway is completely clear. There is absolutely no physical blockage. The paper straw is open, but the baby still stops breathing. Why?
Because the brainstem forgets to send the signal to breathe.
It just forgets.
Yes,
Yeah.
this goes all the way back to the Pur-alpha protein's role in the deepest, most primal part of the brain, the brainstem. The brainstem is the autonomic control center. It runs all the background programs of the body.
The things we never think about.
Right. In central apnea, the diaphragm just stops moving. It waits for a command from the brainstem, and the command doesn't come.
That is utterly terrifying for a parent to watch. Your child is just lying there, no struggle, no choking, just not breathing.
It is the ultimate nightmare scenario. And it is why these babies are often hooked up to pulse oximeters and apnea monitors that sound an incredibly loud alarm to wake the parents.
And then the parents have to do what?
They have to physically stimulate the baby to remind the brainstem to kick back in, just rubbing their chest or jostling them to wake the brain up.
That sounds exhausting for the parents.
It really is. It also explains why these infants suffer from two other major autonomic issues: hypersomnolence, which is excessive sleepiness, and hypothermia, which is severe temperature instability.
Oh, because if the brainstem is dropping the ball on the breathing signal, it's also dropping the ball on the stay awake signal and the shiver to stay warm signal.
Precisely. The master control center is completely overwhelmed and understaffed. However, there is a very important, very real message of hope in the clinical data regarding this intense neonatal phase.
Yes, I was incredibly relieved to read this in the natural history studies. The sources note that while these severe respiratory issues, both obstructive and central apneas, they frequently require mechanical ventilation, CPAP machines, or supplemental oxygen in those early months.
But they don't usually stay that severe forever.
Right. They often show gradual improvement or even complete resolution after the child turns 1.
And that is the absolute magic of neuroplasticity.
Now, how does that work exactly?
Well, as the brain physically matures, as the skull grows and the airway expands anatomically, and as the brain develops new redundant pathways, even with the reduced Pur-alpha protein, the brainstem slowly gains better control over those autonomic functions.
So the brain essentially figures out a workaround.
Exactly. The apneas generally become less frequent and less severe. Now, nocturnal monitoring is often still a requirement for safety, but the acute, life-threatening crisis mode of the NICU generally stabilizes.
So let's trace the journey of a family moving out of that phase. You survive the acute neonatal survival phase, the breathing stabilizes, maybe the apneas are under control with a CPAP, and the feeding is stabilized, perhaps with the help of a G-tube.
You finally get to go home and breathe a little.
Yeah, you finally catch your breath as a parent, and you naturally start looking toward the next phase. You look at the baby books, you look toward motor development.
Sitting, crawling, walking.
Right, pulling up to stand, walking. And this transition requires a profound, often heartbreaking shift in expectations for the family.
This is where we have to talk about the sheer, unyielding resilience required from both the child and the parent. Because society constantly pushes traditional milestones.
Yeah, the baby apps pin your phone and tell you exactly what month your child should be rolling over, what month they should be pincer grasping a Cheerio.
It can make parents feel like they're failing. But persistent central hypotonia remains an enormous, invisible barrier to gross motor development in PURA syndrome.
We have to address the reality laid out directly in the clinical sources, and it's a hard reality to read. Most individuals with PRA syndrome do not attain independent ambulation.
Meaning they won't walk entirely on their own without some kind of physical support.
Right. And for the minority who do eventually learn to walk independently, the timeline is vastly extended. The achievement age for taking independent steps is typically anywhere between 3 and 10 years old.
Think about what it takes to actually stand up. You are stacking a series of joints, ankles, knees, hips, spine in a perfect vertical line, right?
Yeah.
And then you're using dozens of core and leg muscles to constantly make these tiny micro adjustments to prevent gravity from pulling that stack over.
It's a balancing act.
It is. When the central Wi-Fi signal is weak, those micro adjustments are delayed. And when they do walk, the physical manifestation of that central hypotonia is very visible. They typically adopt a wide-based gait.
Why wide-based? Is it because the bones are shaped differently?
No, the bones are initially perfectly normal. They adopt a wide base, spreading their feet far apart, because it physically lowers their center of gravity and increases their base of support.
Oh, that makes total sense. If your muscles are slow to react to a loss of balance, you need a wider foundation so you don't tip over as easily.
Exactly. But even with this compensation, their gait is typically unsteady, making them highly prone to falls.
And it's not just the big movements, is it? The fine motor skills are similarly impacted. Reaching out, grasping a toy, bringing a spoon to their mouth.
Those actions require incredibly complex, sustained muscle contractions. To a neurotypical person, picking up a spoon is absolutely nothing. To a child with PURA, it is a coordinated, exhausting effort of willpower and muscular strain.
Which is exactly why the premise of this deep dive is so vital. We are focusing on redefining progress. The medical world, the therapy world, the parenting world, they are all obsessed with milestones.
Oh, entirely.
But when your child is fighting biological gravity with every single movement, an inch stone is a milestone. It requires the same amount of effort, and it deserves the exact same level of celebration.
I love that. When the world expects a mile and your child fights with everything they have to give you an inch, you throw a parade for that inch.
You really do. But to truly understand why those inch stones are so meaningful and why parents shouldn't give up hope, we need to highlight a fundamental clinical truth about PURA syndrome that is clearly stated in the literature. It is a neurodevelopmental condition, not a degenerative one.
That distinction is paramount. It changes the entire psychological landscape for a parent.
What does that mean practically? Like for a family sitting at home, what is the difference between neurodevelopmental and degenerative?
Well, in a degenerative condition, like certain muscular dystrophies or metabolic disorders, a child might learn to walk or talk, but then the disease actively destroys the tissues or nerves.
So they lose those skills over time. They regress.
Right. PURA syndrome is not like that. The central hypotonia makes the physical output incredibly difficult, and the gap between a child with PRA and their neurotypical peers might seem to widen as time goes on. But the child with PRA is generally not losing skills.
They aren't going backward.
No, they are progressing, they are moving forward, just on a vastly extended, highly individualized timeline.
The brain is continually trying to build those connections. And here is where I found one of the most fascinating and, frankly, most validating insights in the entire stack of sources.
Right.
The massive discrepancy between what their hypotonic bodies can physically do and what their minds actually understand. The clinical data on communication highlights this beautifully.
What's fascinating here is it's a striking clinical feature. The vast majority of individuals with PURA are nonverbal or non-speaking.
Right.
The severe oromotor hypotonia that caused the feeding issues in the NICU, well, it persists into childhood. This makes the incredibly precise, rapid-fire muscle coordination required to produce meaningful spoken words almost impossible.
Right, because to speak, you need your diaphragm, your vocal cords, tongue, lips, and jaw to all synchronize perfectly. If the Wi-Fi signal is weak, you just can't get the timing right.
Exactly. So their expressive language, what they can actually put out to the world verbally, is severely limited. But their receptive language, their cognitive ability to understand what is being said to them, to process the world around them, is excellent.
Parents report this all the time. The sources say these children can follow complex commands. They have favorite TV shows.
They absolutely do.
They understand jokes and possess a wonderful sense of humor, even if they can't physically laugh out loud or speak a single word.
It tells us that their cognition, their receptive processing, is highly functioning. Their minds are bright, active, and taking in absolutely everything in their environment.
The barrier is purely the expressive output.
Yes. The hypotonia is basically trapping their vibrant minds inside a physical vessel that struggles to react.
Which is the ultimate argument for why early implementation of AAC augmentative and alternative communication devices is just non-negotiable. It is critical.
It really is a game changer.
We aren't just talking about giving them a way to ask for a drink. We are talking about giving them a bypass route around their hypotonic vocal cords, whether it's high-tech eye gaze technology that tracks where they're looking on a screen.
Or touch screens if they have the fine motor control.
Right. You are giving their social minds a way out.
And they are incredibly social. The clinical summaries repeatedly describe individuals with PURA as affectionate, friendly, having a happy disposition, and giving the best hugs. Their desire to connect is profound.
Which makes it all the more important to obsessively look after their physical vessels. Because, and this is a heavy pivot, but a necessary one, if a child is primarily non-ambulant, meaning they use a wheelchair, or they are severely delayed in walking, there is a hidden structural domino effect taking place deep inside their bodies.
This is where we move from neurology into orthopedics and biomechanics, and we have to talk about how the human skeleton actually works. We tend to think of our skeleton as this static, dead scaffolding that our muscles just hang off of, like the steel beams of a building.
But it's not. It's living, dynamic tissue.
Exactly. And living bone tissue follows a biological rule called Wolff's Law.
Wolff's Law. Okay.
In simple terms, Wolff's Law states that bone grows and remodels itself in direct response to the mechanical forces placed upon it.
So, to grow strong, thick bones, you have to stress them.
Yes. You have to pound on them. You have to have strong muscles tugging and pulling forcefully on the bone surface.
Okay, I want to use an analogy here to make this crystal clear. Think about astronauts going up to the International Space Station.
Okay, I like this.
These are peak physical specimens, perfectly healthy. But when they get into orbit, they're required to strap themselves into specialized resistance machines and exercise for 2 solid hours every single day. Why? Because without the constant, heavy, relentless downward pull of Earth's gravity, and without the stress of their muscles actively fighting against that gravity, the astronauts' bones get confused.
Right, the body says, hey, we don't need all this dense bone mass up here.
Exactly, and it starts reabsorbing the calcium. They lose bone density rapidly. A child with severe essential hypotonia is essentially experiencing an astronaut's reality right here on Earth.
That is a brilliant way to conceptualize the biomechanical reality. Because these children lack dynamic, forceful, weight-bearing like running, jumping, or even just standing for long periods.
Right, they aren't pounding the pavement.
And because their hypotonic floppy muscles aren't exerting those strong, sharp pulls against the bone, they face severe, progressive, secondary complications. The skeleton just doesn't develop correctly.
Let's look at the spine first, because the sources show it's a major area of concern.
It is. Scoliosis, which is an abnormal, sideways curvature of the spine, affects approximately 48% of the PURA population.
Almost half. That's huge. And why does the spine curve? Is the bone growing wrong initially?
No, it's not the bone's fault originally. Think of your spine like a flagpole, and the core muscles on your back and stomach are the guy wires holding it straight.
Okay.
If the guy wires on the left side are pulling with 10 pounds of force, and the guy wires on the right side are hypotonic and only pulling with 2 pounds of force, what happens to the flagpole?
It bends toward the stronger side.
Exactly. The asymmetrical muscle tone, combined with the lack of core strength to hold the spine vertical against gravity, causes the spine to gradually bow and twist.
And in many cases in PURA syndrome, this curvature is progressive, right?
Yes.
Yeah.
It gets worse as they grow, often requiring major surgical stabilization like spinal fusion rods, just to maintain their ability to sit upright comfortably in a customized wheelchair.
And to prevent the collapsing rib cage from physically crushing their lungs.
Yes, that respiratory compromise is a massive risk with severe scoliosis.
It really is the domino effect. The weak Wi-Fi signal in the brain leads to weak muscles, which leads to a curved spine, which leads to compromised lungs. And the dominoes fall toward the hips too, don't they?
They absolutely do.
The scoping review on developmental central hypotonia that we looked at is incredibly specific about this. It shows that the incidence of hip subluxation or hip dysplasia ranges from 11% to 28% in these kids.
And this is another perfect example of Wolff's Law in action. Let's explain the geometry of a hip joint. It is a ball and socket joint. The top of the femur, the thigh bone, is the ball, and the acetabulum in the pelvis is the socket, the cup.
But babies aren't born with deep cups, right? They're
Right.
pretty flat.
Correct. Babies are born with very shallow hip sockets. For that socket to form into a deep, healthy, secure cup during early childhood, the ball of the femur has to press firmly and repetitively into the cartilage.
And that happens when they move around.
Right. This grinding, weight-bearing pressure usually happens naturally when a baby starts crawling, kneeling, pulling to a stand, and walking.
So if a child with PURA isn't standing or walking due to hypotonia,
That essential grinding pressure never happens. The socket remains shallow and flat. Add in the fact that their ligaments and joints are incredibly lax and stretchy because of the low tone, and the hip ball essentially just slides right out of the shallow cup.
oh wow, that is a subluxation.
Yes, a partial dislocation.
And reading the surgical literature, fixing this isn't just popping it back into place, is it?
No, because there is no deep cup to hold it. It often requires incredibly complex orthopedic surgeries. You mentioned earlier the term varus derotation osteotomies. I know that sounds like intense medical jargon.
Yeah, please unpack that because parents will absolutely see that term on surgical consent forms and it sounds terrifying.
An osteotomy literally means cutting the bone. In a varus derotation osteotomy, the surgeon actually cuts the top of the femur bone, re-angles it so the ball points more directly and securely into whatever shallow socket exists, and then secures it with metal plates and screws.
So they are artificially altering the geometry of the leg.
Yes, to force the joint to stay together because the muscles can't do the job.
So what does this all mean? Like, for the parents listening, we are not outlining these terrifying surgical realities to be alarmist or to scare you.
No, not at all.
We're talking about this because understanding the mechanism behind why the spine curves and why the hip slides out gives you immense power.
We are talking about it because knowledge allows for proactive, preventative surveillance. If you know the domino effect is coming, you can intervene before the dominoes fall.
And that extends to general bone health as well, right?
Absolutely. The combination of limited mobility, chronic hypotonia, and frequent vitamin D deficiency leads to a very high risk for osteopenia, low bone density, and full-blown osteoporosis in these children.
And we also have to factor in the compounding effect of medications here,
Yeah.
because over 50% of individuals with PRA also battle complex, hard-to-treat epilepsy.
Which is a huge factor.
Right. They are often on multiple heavy-hitting anti-epileptic medications day in and day out for years.
And those medications, while absolute lifesavers for stopping seizures, have known side effects. Many of them interfere with vitamin D metabolism in the liver. They literally leach calcium out of the bones, further weakening a skeleton that is already compromised by the lack of weight bearing.
Meaning these children are at a drastically elevated risk for pathological fractures.
Yes.
We're talking about bones breaking not from a high-speed car crash or falling out of a tree, but from normal, everyday handling.
Sadly, yes. A minor bump against a door frame, or even just aggressively doing physical therapy stretches, could snap a femur.
And before we move off the structural issues, we have to mention the internal plumbing, the digestion.
Yes, because the intestines are also made of smooth muscle. They rely on rhythmic contractions, peristalsis, to push food through the digestive tract.
And if that muscle is hypotonic,
Exactly. Intestinal hypotonia, combined with the fact that the child has low physical activity and isn't up and walking around to let gravity help move things along, leads to near universal, chronic, severe constipation. The bowel muscles just aren't contracting forcefully enough.
but again, knowing this empowers the parent. You don't wait for your child to scream in pain from an impacted bowel. You establish an aggressive bowel management protocol with Miralax or other osmotic laxatives from day one.
Exactly.
You don't wait for a femur to snap to ask for a DEXA bone density scan. You push your pediatrician for vitamin D supplementation and baseline spinal and hip x-rays early on before severe curvatures or subluxations occur. You treat the predictable consequences of the hypotonia before they become massive emergencies.
It shifts the paradigm from reactive medicine putting out fires to proactive, preventative care.
Which brings us perfectly to the next vital phase of this deep dive, taking action. Now that we understand the deep biological origin of the floppy muscles and the hidden mechanical impact on the bones, the hips, and the airway, How do parents and medical teams safely intervene?
The sources, particularly the insights from therapeutic organizations like the Napa Center, emphasize a multidisciplinary approach.
Multidisciplinary is kind of a buzzword, but practically, what does that mean here?
It means you are assembling an entire team of specialists to attack the hypotonia from multiple angles simultaneously. The therapeutic approach has to be holistic.
So let's break down the big three: PT, OT, and speech.
Physiotherapy, or PT, is going to focus on the gross motor. They are actively working on improving that baseline tone, building core strength to protect the spine, and practicing balance. They're trying to stimulate the nervous system to fire those muscles.
And occupational therapy.
OT gets more granular. They target upper limb function, hand-eye coordination, and fine motor skills.
So things like grasping.
Yes, so the child can eventually grasp their communication device, maneuver a power wheelchair joystick, or help with self-feeding.
And speech pathology. We covered the AAC devices earlier, but speech is also crucial for the dysphagia, right?
Absolutely. Speech-language pathologists are experts in the anatomy of the throat. They work on the feeding and swallowing mechanics to prevent aspiration, while simultaneously establishing those vital alternative communication pathways early on.
And I think it's so important for parents to hear this. Relying on durable medical equipment is not a sign of defeat.
No,
It is a tool for freedom.
I cannot emphasize that enough. There is often a grieving process when a parent realizes their child needs a walker or a wheelchair.
But think about what we just discussed regarding bone health and spine alignment. Walkers, gait trainers, customized standing frames, molded seating systems. These aren't just accessories.
They are medical necessities.
Right. They artificially provide the rigid external postural support that the child's hypotonic muscles cannot. They substitute for the weak Wi-Fi signal. They hold the physical hardware in proper alignment so the child can actually look up, interact with the world, and play rather than spending all their energy just trying not to fall over.
They preserve the skeleton while enabling the mind to explore.
But even with all the therapy and all the equipment in the world, there is a very critical, highly dangerous medical intervention area we must discuss in depth,
Yes.
and that is surgery. Because of the scoliosis, the hip dysplasia we detailed, the dental decay from GRR, or the need for a G-tube placement, almost every child with PURA syndrome will eventually require some form of surgical intervention.
This raises an important question. How does a child with severe central hypotonia actually handle general anesthesia?
Right.
According to the highly specific orphan anesthesia guidelines included in our sources, the answer is very precariously. The risks are extreme, and they must be managed meticulously.
Okay, I want to create a massive aha moment here for the listeners because when I read this in the sources, my jaw literally dropped. Think about what general anesthesia is designed to do to a healthy neurotypical body.
It does exactly what you think.
The anesthesiologist administers drugs that intentionally paralyze the muscles-inducing artificial hypotonia, and they administer heavy narcotics that intentionally depress the central respiratory drive in the brainstem so the patient doesn't fight the breathing tube.
Do you see the profound biological irony here? General anesthesia chemically induces the exact physiological state hypotonia and central respiratory depression that a child with PURA syndrome already suffers from at baseline.
You are artificially compounding the exact life-threatening symptoms they already fight every single day. You are pouring gasoline on a fire.
Precisely. You are taking a brainstem that is already struggling to remember to breathe, and you are hitting it with heavy suppressants. This is why the orphan anesthesia guidelines are so incredibly strict, and why parents must be hypervigilant.
What's the first guideline?
First and foremost, patients with PURA show an extreme, magnified sensitivity to respiratory depressants.
So standard dosing is incredibly dangerous.
It can be lethal. The official recommendation is a mandatory 50% reduction in the standard weight-based doses of opioids, like fentanyl or morphine, and benzodiazepines, like midazolam.
A 50% reduction.
Yes, their brainstems simply cannot handle the normal pharmacological dosages without completely failing to trigger a breath.
And because of that lingering magnified apnea risk, the guidelines state there should be absolutely no such thing as day surgeries or outpatient procedures for these kids.
Never. You do not get the G-tube placed or the dental work done and go home at 5:00 p.m. It doesn't matter how minor the actual surgical procedure is. It is the anesthesia that is the primary risk.
So they have to stay overnight.
Mandatory 24-hour inpatient hospital monitoring is required post-surgery with continuous pulse oximetry and apnea alarms. because even as the child wakes up and seems totally fine in the recovery room, the lingering, slow-clearing effects of the anesthesia can trigger massive central or obstructive apneas hours later in the middle of the night.
That is so scary. Furthermore, we talked about the floppy airway collapsing like a paper straw. Because of that severe oropharyngeal hypertonia, their upper airway is incredibly prone to collapsing during the recovery phase when the breathing tube is removed.
Which is why anesthesiologists should proactively use nasopharyngeal airways. Instead of just pulling the main breathing tube out and hoping the throat stays open, they insert a soft, flexible silicone tube through the nose and down into the back of the throat.
Oh, to physically stent the airway open.
Exactly. It provides a rigid tunnel for air, preventing that floppy tissue from collapsing while the child sleeps off the anesthesia.
And finally, because of the autonomic dysregulation we discussed, the brainstem struggling with temperature control, they are at an extremely high risk for rapid hypothermia in a freezing cold operating room.
Those rooms are freezing.
So active warming measures, heated blankets, warmed Hovey fluids, are mandatory protocols from the minute they enter the OR.
This section of our discussion is practically a survival checklist. If you are a parent, print the orphan anesthesia guidelines out, highlight them, hand them directly to the anesthesiologist during the pre-op consult.
Don't assume they know.
Right. Do not assume they know about PURA syndrome because it is ultra rare.
Because understanding the biology, knowing about the 5q31.3 locus, the brainstem involvement, the central versus peripheral distinction, it gives you the exact, precise medical vocabulary you need to advocate fiercely for your child's safety when they are lying unconscious on an operating table and are at their absolute most vulnerable.
It completely shifts the dynamic. It moves the parent from being a terrified, passive observer in the waiting room to being an active, informed, indispensable member of the medical team.
As we start to bring this massive deep dive to a close, let's look back and recap the incredible journey we've just taken through the human body. We started at the microscopic level, looking at a single gene variant on chromosome 5.
We saw how the reduction of one specific project manager protein, Pur-alpha, turns down the volume on the brain's Wi-Fi signals to the rest of the body.
And we traced how that one single mechanism, central hypotonia, connects absolutely everything. It explains a newborn's terrifying struggle to coordinate a swallow and a breath in the NICU.
It explains a 7-year-old's need for a customized gait trainer.
Exactly. It explains the necessity of bone density DXA scans, hip x-rays, and aggressive constipation management in adolescents.
And we've seen why, deeply understanding the mechanical why and how behind Floppy Baby syndrome is so crucial.
It removes the dark mystery. It replaces the paralyzing fear of the unknown with actionable medical surveillance, targeted therapeutic interventions, and confident advocacy.
To the parents, the carers, the siblings listening, we know the medical realities of PURA syndrome are incredibly relentlessly challenging. We know reading these clinical papers can feel like looking at a mountain you have to climb every single day.
But we also hope this deep dive into the sheer mechanics of hypotonia validates the immense, heroic effort your children put into every single movement they make. When your child fights to lift their head off a mat, when they strain to reach out a hand for a toy, when they use an eye gaze machine to tell you a joke.
They are doing the physiological equivalent of a neurotypical person running a marathon with weight strapped to their limbs.
They are battling the invisible, crushing force of biological gravity, and that makes every single inchstone a monumental, breathtaking victory.
Their resilience is staggering. They are warriors. And as the global scientific community continues to aggressively research the Pur-alpha protein and the exact pathways of neuroplasticity, our understanding of how to medically and therapeutically support them will only grow stronger.
Here's where it gets really interesting, though. I want to leave you with a final, empowering thought to ponder as you look toward the horizon. For decades, the medical approach to severe physical disability has always been about fixing the body to fit the world. But we live in an era of rapidly accelerating technology. We have advanced brain-computer interfaces being developed that can read neural signals directly. We have AI-driven predictive eye-tracking communication devices becoming incredibly sophisticated and fast.
We even have zero-gravity, robotic exoskeleton physical therapies emerging.
So what if the future of supporting a child with PURA syndrome isn't just about grueling physical therapy to force their hypotonic muscles to catch up to our heavy gravity-bound world?
What if instead we use engineering and technology to redesign the physical world around them?
Exactly. What if we design a world that seamlessly connects with their bright, highly active, and fully capable minds, bypassing the physical limitations of their hypotonic bodies entirely? A world where gravity is finally neutralized, where the weak Wi-Fi signal doesn't matter anymore, and their brilliant inner voices can finally ring out loud and clear. Keep fighting for those inch stones. We see you, we honor your journey, and we are cheering you on.